Thank you. Happy to be here and excited to be part of this new conference. So today what I'm really going to talk about is basically modeling complex human immunology, immune reactions, particularly those that relate to inflammatory diseases like inflammatory bowel disease. We really like this quote from the president of the American Association of Immunologists from this year's meeting. We're definitely ready for human immunology at Emulate, and we're hoping that the work that we're doing now is going to help advance this exciting area. So just quick overview. I'm going to introduce the basic Emulate platform, our colon chip, and then the meat of what we really want to talk about is how we're going to model immune cell recruitment dependent IBD and then test therapeutics against it. So let's see if this video plays. Oh, it does. Okay, so this is the S1 chip, which is sort of the core of our technology. It's a two-channel microfluidic device that has an upper and lower chamber. We typically, separated by a microporous membrane. We typically see the upper chamber with the resident tissue, in this case, human biopsy-derived organoids from the colon. And the lower chamber is microvascular endothelial cells, also derived from the colon. These are co-cultured and co-matured and subjected to mechanical inputs like cyclic stretch, which models the peristalsis in the gut or the breathing of the lung. And then we perfuse the channels with media, which allows to nutrients and target agents to be delivered, but also provides the input of mechanical forces that are relevant for differentiation. So that is the sort of the fundamental starting point that we work with. This is a slide just in case that video fails. And that's supported by our pods, which are where the chips reside. And this provides reservoirs for the fluidics, which are then supported by the Zoes and the Orbs and the software that manages all of the detailed fluidic parameters. So IBD is the disease that we decided to model for a number of reasons. One of which is it's an enormous area of unmet medical need. About half of all patients are able to, or unresponsive to existing therapies, and a large fraction of those that do respond ultimately fail to reach remission or become unresponsive to those drugs. So there's a really enormous need for new therapeutics in this area, and likewise, there's a strong need for new models. I'll just say briefly that the existing animal models have a number of limitations, not the least of which is the incompatibility of species-specific differences, I should say, in the immune responses. And the existing culture models or organized also have limitations, especially in the space of complexity. And one particular aspect is lack of vasculature. So this is how Emulate has approached this. As I've already mentioned, we work with biopsy-derived primary human collonoids, which are then fragmented, seeded into the upper chamber. We seed microvascular cells from the colon as well as in the lower chamber. And I don't have time to go into all of the detailed validation and characterization that's gone into this model, but I can just say briefly that it really is a very complete model which really reflects the primary human physiology beautifully, and just highlight a couple of those features. First of which is barrier function. We're seeing on the left, the scheme of a permeability assay where we introduce a Cascade Blue tracer in the upper chamber, and we monitor the egress of that tracer, and that gives us permeability or plots that are shown in the graph next to that. And in both cases, on these two curves, we're seeing at day 8, we get really strong barrier function, low permeability. But one of the features that this graph is also highlighting is the difference between the black, the epithelium cultured in the absence of endothelium, and the blue, which shows that the endothelium really stimulates rapid differentiation of this model. So there's a real codependence, and these cells are really beautifully reflecting the physiologic function as well as morphology, such as the microvilli that you're seeing on the right. Lastly, I just want to highlight that the transcriptome profile of these of the chip or colon chip really nicely, closely reflects the human transcriptome profile and far outperforms traditional organoids. So in short, this is a really beautiful physiologic model on which to build complexity and to model inflammatory responses that reflect IBD. So IBD is a very complex chronic human disease. It involves recruitment of diverse immune cells from the blood circulation and subsequent complex networks of cytokines and chemokines, which ultimately culminate in disruption of the epithelial barrier, mostly through the sort of distal cytokines, interferon gamma and IL-22. So as an early sort of proof of principle model of IBD, we just introduced interferon gamma and IL-22 directly into the model. And what we can see is by the permeability response that quickly and rapidly is elevated, and the tight junction dissolution, that we can recapitulate this distal endpoint of the disease. But as we said, the true progression of IBD is much more complex, and its heart is recruitment of immune cells. In fact, that's true of all major human diseases. It's a fundamental progression where the immune cells are called into the tissues and develop interstitial reactions. So our goal was to recapitulate that complete process with the assumption that if we did that well, that we would enable models to more meaningfully develop human therapeutics. And so we have a very physiology-forward ethos in developing these models, so we really need to track what the underlying process is and do our best to recapitulate that. And so when it comes to immune cell recruitment, there's fundamentally these four phases. There's always a priming step. So the tissues undergo some kind of stress, some damage, maybe infection, and that cues local chemical changes, specifically cytokine and chemokine release, that reprogram the local tissue microenvironment, and particularly the endothelial cells, to express adhesion molecules and chemoattractants that are going to call the immune cells in. So that's the second step. The immune cells get bind and attach and move in, and then they have to undergo immune reactions, which locally in situ, which are an interplay between the diverse immune cells and the stromal cells, which ultimately lead to some kind of tissue response and damage that drives disease. So this slide just kind of gives you an overview of how we're modeling that. I've already introduced the colon chip. What we do is fundamentally we seed those chips, we allow them to co-differentiate, and they remain in the resting healthy state, or we subject them to the priming signals that I've already mentioned. Specifically for IBD, we're introducing tumor necrosis factor alpha, or TNF-alpha, which is well-established initiating cytokine in IBD and a therapeutic target for that disease in its own right. Additionally, we add IBD-specific chemoattractants in the upper chamber to drive the immune cells into that compartment as they would under normal physiologic, or I should say pathophysiologic conditions in the human. And then we take either these resting prime chips and we perfuse peripheral blood mononuclear cells into them, and we ask how much adhesion and recruitment do we see. In this upper panel we're seeing, you could probably barely make out the specks of pre-fluorescently labeled immune cells at low magnification. And this lower panel shows you sort of the confocal imaging, which separates out the cells at the bottom and those that have migrated up. And I'll just say briefly, we don't have time to go into it, that we've developed really robust and sophisticated automatic quantification schemes which can output all of this data really robustly. So in developing a disease model, as I said, we really need to be physiology forward. So we have focused on these three strategic goals as guideposts to make sure that we're achieving a physiologically relevant model. First goal is to assure that we're generating inflammation-specific recruitment. And so what do I mean by that? Well, we all have billions of immune cells circulating inside of our circulation right now, and the vast majority of them are staying put. Only at specific space and time where the tissues have undergone a pro-inflammatory priming signal should you get immune cell recruitment. So we're tracking that and monitoring that mostly with our imaging. Secondly, once those cells are there, we need to show that they drive inflammatory responses, but not just any responses that model the tissue and disease-specific conditions that we're trying to emulate. And so for that, and particularly multiplex cytokine analysis of the effluent and barrier function, both capturing critical hallmark features of IBD are what our readouts are. Lastly, the whole purpose of this exercise is to develop therapies that are going to be meaningful. And so the goal here, or the approach, is to test those above IBD readouts against clinically relevant IBD therapeutics. So in the next few slides, I'm going to just tell you about what we've done to try to speak to each of these goals. For those of you who are interested, this is just sort of a flight plan of our 8-day experiment, which just gives you an overview of that's color-coded. The gray is sort of the preparation steps in the chip. All the magenta is the experimental manipulation itself, like the priming, the drug and PBMC perfusion. The blue are the readouts, effluent analysis, permeability measurements, and imaging. So this shows you there are sort of the data that we've acquired to speak to this first goal. This is inflammation selective recruitment. So what you can see in this plot is in the resting chip, very few immune cells are attaching or being recruited, but we get a robust selective response only on the prime condition. That is critical because we really need to reflect that level of physiologic selectivity. And we have some nice images on the right sort of capturing that. Now, just briefly, I want to say that we discovered that the fluid forces at which that we perfuse these immune cells are critical to achieving this selectivity. On the left, what we call high flow is a flow rate that's at the lower end of physiologic relevance. But when we go far below that flow rate to non-physiologic rates, you see you've got indiscriminate attachment of the immune cells to the resting chip. So that's a critical parameter we can talk about later if people are interested. An additional level of selectivity is we show that the cells that are recruited are marked with specific molecules that mark the intestine-specific subset of immune cells. There's a fraction of alpha-4 beta-7 CCR9 cells that are born to circulate specifically to the intestine, and we can show that these are enriched as you would expect. So we're getting that selective recruitment. What are they doing? Well, in fact, we can see that they are secreting the signature IBD cytokines, IL-22 and interferon gamma, as is shown here. So that suggests that they're making progression toward developing a true IBD-like phenotype. And if we go to the next step and look at permeability responses, we can see, in fact, that is exactly the case. So I'll just briefly take you through this. The negative control in black is basically a normal progression of epithelial maturation, and when it reaches the nadir there at day 5, no further manipulations are made, and that you can see the barrier function stays stable. All the way to the other side of the slide in yellow, we can see the positive control. When we directly administer interferon gamma, we get the predicted immediate robust permeability response. But when we look at the teal and magenta curves, that's what we're getting when we're introducing PBMCs. You notice that the teal is the condition where there's no priming and no recruitment, and you see no permeability response. However, when we have a priming and PBMC introduction where we get robust recruitment, we're getting a nice selective loss and barrier function. This is non-trivial because now, to our knowledge, for the first time, we're recapitulating the full progression of disease pathogenesis, starting with the priming, moving to attachment and recruitment of immune cells, interstitial development of inflammatory reactions, including the release of the terminal cytokines IL-22 and interferon gamma, ultimately leading to a barrier disruption response. This implies that we're capturing a much more complex and complete set of pathogenic processes, and what's further implied is that we're capturing a more complete set of therapeutic targets, and that's what's really exciting for us. And before I tell you about what we're doing on that front in the last couple of slides, I'll just briefly say that the imaging work that we've done nicely reflects the ability of the PBMCs to induce barrier dysfunction at the level of tight junction dissolution. But as I said at the onset, what we're really interested in is using this model to drive therapy development, and specifically that we are going to use clinically irrelevant IBD therapies that are either in the clinic or on their way to do that. And so specifically, we've looked at dexamethasone, a corticosteroid that functions to suppress pro-inflammatory transcriptional reactions. In this case, dexamethasone is predicted to block the TNF-alpha-dependent upregulation of adhesion molecules like MAdCAM on endothelium, and therefore act to suppress recruitment. AJM300 and Entyvio are small molecule and biologic drugs that both act directly to interact with the integrin and therefore interrupt the adhesion and block recruitment in that regard. So I'll tell you just a little bit of the data that we've generated. First, at the level of recruitment. Here you can see two sets of plots, both looking at the selective recruitment of immune cells in the absence and the presence of drug. You can see that dexamethasone and AGM both have pretty effective abilities to reduce the recruitment. But you also notice that we can get a sort of rank order. Clearly, dexamethasone is only about 50% effective, whereas AGM is about 90% effective. So what about downstream effector responses? Here we're looking at cytokine release, particularly IL-22, and again comparing dexamethasone and AGM. And what's nice is you can see they both are suppressing, but they both are also reflecting a similar magnitude of response as we've seen in terms of the recruitment, so about 50 versus 90%. And lastly, if we turn to the barrier function, we can see that, not shown here, dexamethasone had a pretty marginal effect, but AGM, in keeping with its efficacy at the level of recruitment and cytokine suppression, really nicely protects the barrier, or keeps the barrier intact and protects it from the immune cell recruitment, as is further reflected in the protection of the tight junctions. So basically what I've told you is that we've now set up a model whereby we start with a highly physiologic model of the vascularized human colon, and then simply by introducing the appropriate IBD-relevant priming cues and perfusing PBMCs, we can recapitulate the full cascade of disease, including the attachment, the recruitment, interstitial immune reactions that ultimately lead to barrier disruption. So we're really excited about the potential of this model, this platform as a whole, not only for the immediate purposes that we've just talked, but for developing analogous inflammatory disease models in other tissues on which to develop therapies, as well as the potential to use this sort of platform to likewise develop immune cell therapy recruitment and effector response studies. So with that, I'll stop and take questions if we have any time.